This is my Preparator series for NEET PG. Concise, exam oriented notes for first revision. Let's start. Today we are revising acne integrated in the subject dermatology with an exam oriented approach. The first concept in acne is the organ which is affected in acne. Here, the organ which is affected is the pilosebaceous unit in the skin. The next concept in acne is etiology of acne. Climate change, diet change, emotional stress, facial cosmetics, genetic predisposition, premenstrual flare, polycystic ovarian syndrome are the etiological factors for acne. In diet change, the most important cause is intake of foods which contain high glycemic index. Examples of those kinds of foods are sweets, milk, fast foods, and bread. The next concept we have is pathogenesis of acne. It happens via three pathways. The first pathway is due to increase in the secretion of androgens, which is resulting in the increased activity of sebaceous gland. The next pathway is due to increased secretion of interleukin 1 and IGF-1, which leads to hyperkeratinization of infundibulum of the pilosebaceous unit. Next is due to the increased colonization of Cutibacterium acnes in the pilosebaceous unit. All these three leads to inflammation and acne formation. The next concept we have in acne is the morphology of acne. So, acne is a polymorphic in morphology, which means at any given time we can see all the different types of lesions in skin. The next concept we have is grading of acne. Grading is based on the predominant lesion which you are seeing at the time of examination. Grade 1, the predominant lesion you can see is comedones. In grade 2, the predominant lesion is papules. Grade 3, the predominant lesion is pustules. And in grade 4, the predominant lesion is nodules and scars. As you can see in the image, image 2 and image 3 are blackheads and whiteheads respectively, which are known by the medical terminology comedones. These are related to grade 1. The first image represents the papules and these are related to grade 2, and the fifth image is pustules and it is related to grade 3. Image 4 and image 6 are nodules and cysts respectively. These are related to grade 4. The next concept we have in acne is management. Management is also based on the grading of acne. For grade 1, we use topical retinoids. For grade 2, we use topical retinoids plus topical antibiotics. For grade 3, we use topical retinoids plus oral antibiotics plus or minus benzoyl peroxide. For grade 4, we use oral retinoids. Now let's see what are all the drugs in each of these classes. In topical retinoids, we have tretinoin and adapalene. In topical antibiotics, we have clindamycin and nadifloxacin. In oral antibiotics, we have azithromycin, doxycycline, and minocycline. In oral retinoids, we have isotretinoin. When we are prescribing isotretinoin, we must be expecting certain side effects. And the common side effects which are related to isotretinoin are cheilitis, teratogenicity, deranged LFT, and hypertriglyceridemia. How can we manage these side effects? For cheilitis, we can use a moisturizer. For teratogenicity, the drug should be stopped 1 month before the conception. For deranged LFT, we can track it with the help of LFT, and for hypertriglyceridemia, we can track it by means of fasting lipid profile. The next concept we have in acne is syndromes related to acne. First syndrome is Sappho syndrome. The components of this syndrome are synovitis, acne, pustulosis, hyperostosis, and osteitis. The next syndrome is Hair-An syndrome. The components of these syndrome are hyperandrogenism, insulin resistance, and acanthosis nigricans. The next syndrome is Saha syndrome. The components of this syndrome are seborrhea, acne, hirsutism, and androgenetic alopecia. The last syndrome related to acne is Papa syndrome. The components of this syndrome are pyogenic arthritis, pyoderma gangrenosum, and acne. The last concept related to acne is differential diagnosis. The first differential is rosacea. Here we can see the difference between acne vulgaris and rosacea. In acne vulgaris, comedones are present, whereas in rosacea, comedones are absent. The background is oily in acne vulgaris, whereas it is red in rosacea. Distribution wise, in acne vulgaris, it is distributed in the face, upper trunk, and shoulder, whereas in rosacea, it is distributed in the centrofacial area of the face, sparing the periocular and perioral regions. The next differential is acneiform eruption. Here we can see the difference between acne vulgaris and acneiform eruption. Acne vulgaris is polymorphic, whereas acneiform eruption is monomorphic in morphology. Comedones are present in acne vulgaris, whereas they are absent in acneiform eruption. Etiology wise, acne vulgaris can be either physiological or hormonal in origin, whereas acneiform eruption is due to the drugs. The drugs which are implicated in acneiform eruption belong to four classes. The first class is topical or systemic steroids. The next class is anabolic steroids. The next class is anticonvulsants. And the last class is anti-tuberculosis drugs. In anabolic steroids, we have danazol and stanozol. In anticonvulsants, we have carbamazepine, phenytoin, and phenobarbital. Whereas in anti-tuberculosis drugs, we have isoniazid and pyrazinamide. Of these drugs, I am going to remember three important drugs. The first one is topical or systemic steroids because it is the most common cause of acneiform eruption worldwide. The next drug which I am going to remember is phenytoin because it is a commonly used drug in our hospital settings. And the last drug which I will remember is isoniazid because it is the most common cause of acneiform eruption in India. That's it for this topic. See you in the next one.